Thanks, Pradeep. So I'm actually filling in for Dr. Gauri Murthy. She requested me to do this, and I think thank Pradeep for allowing me to do this talk. So I think we all know that ocular hypertension is the most important modifiable risk factor for glaucoma today. And we all know that we call it ocular hypertension when the pressures are more than 20-21 meters of mercury on more than a couple of occasions. Fields are normal, there are normal optic nerve heads, and angles are open. Having said that, there is a bit of modification where we could technically consider ocular hypertension to a certain extent, although they're classified as VAC. And even patients who have secondary cases of ocular hypertension from post-surgical could also be included in this, because at the end of the day, we are looking at the risk factor in total and not just what the final outcome is here. So all we do know that ocular hypertension may eventually evolve into open angle glaucoma over a period of time. How much time depends, at least it's what is projected from multiple studies are 5 to 10 years. So approximately 5% of people over the age of 50 could have ocular hypertension, and if untreated, according to some of the studies like the EMGT and the OATS, they have reported that 1 in every 10 people with OATS will definitely develop damage over a 5-year period after diagnosis. So do we treat all patients with ocular hypertension? The implications are huge. There is a cost factor, there's a problem with the quality of life. We all know that glaucoma patients are sort of labeled as having disease, and it is in many ways, including India and other countries, a social stigma to walk around medications. There are side effects of the medications. It's a lifelong treatment. There are issues with compliance, and at the end of the day, there are benefits about how effective this really is. So we as doctors have the responsibility of providing patients with care based on evidence that is currently available and not what is anecdotal. So if you look at a meta-analysis that was done recently, so a couple of large-scale RCTs, including the European Glaucoma Prevention Study, the Ocular Hypertension Treatment Study, the Early Manifest Glaucoma Trial, and a few smaller RCTs using multiple methodologies are available. And the OATS study, as we all know, was a large multi-center trial done out of the US, where they looked at people, about 1,600 people with ocular hypertension, and they took glaucoma medication versus observation and found that the treatment reduces the 5-year risk of developing glaucoma by half. Having said that, it did not completely negate or stop glaucoma from developing, even in those that were treated in all patients. So less than 10% of subjects in either group developed glaucoma over a 5-year period, which means that even if we didn't treat, many of them did not develop glaucoma. So that's the major question here. So then they looked at the number needed to treat, and they found that it was about 5.1 would be the estimated risk reduction. So if you look at the number needed to treat, which is about 20 by calculating the relative risk, you actually found that you have to actually treat 20 patients for 5 years to prevent one person from progressing to glaucoma. Now, when that is called glaucoma, it could be a structural change or a functional change. So you're looking at maybe one little nerve fiber defect or a hemorrhage, and that is the big question you have to answer. So the number needed to harm was about 2.1, which means that 1 in 48 patients would require cataract surgery due to long-term treatment to prevent glaucoma, which is not bad if you're looking from the cataract surgeon's point of view. Visual field loss, an outcome more likely to be associated with decreased quality of life. Then if you take that as the end point and not just structural change alone, then you're looking at the treating 40 plus patients over 5 years to prevent one person from developing or progressing to the next stage of glaucoma, next stage which is glaucoma. And in blindness, almost improbable, because you're looking at treating 80 patients over 15 years to prevent one person from progressing. Cost effectiveness, and it would take almost $90,000 to prevent one person from progressing to POAG over a 5-year period. If you look at the cost burden on the patient, or in this case, on the US government, if you look at it that way. So, should we not treat all ocular hypertensions? Those with definite risk factors, increasing age, thinner corneas, vertical Doppler ratios of more than 0.7, which is not really acceptable in our current practice as glaucoma specialists, because we all know that 0.7 is nothing but a number. We have to look at the neuroretinal rim. If there is a defect, that should be something that would have been added on and should have been at that point in time, which they couldn't modify obviously later. And central corneal thickness was added as a second, as a major endpoint or as a risk factor much later. It was more of a post-hoc analysis. Then pattern standard deviation and intraocular pressure were all considered sort of added risk factors. I have explained this. So both ocular hypertension with increased IOP and inverse relationship with central corneal thickness. So they developed a few risk factors and risk calculators. I will skip these. So the other important risk factors they found that, especially from the early manifest glaucoma trial conducted in multicenter trial in Europe, that pseudoexfoliation was a major risk factor, and that obviously could not be studied in the US because that's not a very prominent or a prevalent sort of manifestation there. POAG, the other eye, and trauma are also added risk factors. So there are multiple studies on open-angle glaucoma. The early manifest glaucoma trial was a long follow-up trial of about 10 years and recruited a large number of patients, and the entry criteria were mean deviation of -4 decibels and median IOP of about 20 millimeters, and randomized to initial treatment with a selective beta blocker and ALT, or left untreated until signs of progression appeared. So, and here they actually highlighted that every 1 millimeter of IOP reduction was associated with a risk reduction of 10 to 13%, which is you're getting a relative risk of 1, and that is to be thrown out of the window if you look at it, because a relative risk of 1 just says it's equivocal, but that is grossly highlighted by many of the pharmaceutical companies, and it still is, and we still follow that. The rate of progression in early manifest glaucoma trial, they found that it's variable and difficult to predict even in those that are being treated. So most patients eventually progress to some extent, even if pressure is always normal, and that is the take-home message in many ways, because you can treat as much as you like. There are obviously other vascular factors and other extraneous factors that are causing the progression. And mean IOP fluctuation was not found to be a risk factor when the mean IOP was taken into account. So take-home messages from the EMGT were follow progression closely and reset target if required, and measure the IOP and test fields frequently, beginning at the beginning of diagnosis, and to sort of have a baseline and then to assess the rate of progression. Target pressures may have to be reset as you treat the patient, depending on whether he or she is not progressing or not. And it is important to identify and recognize pseudoexfoliation as a major risk factor. And this is more so even in a country like India, where pseudoexfoliation is reasonably prevalent. Now, what is the issue with how we adapt this? This is important. Do we extrapolate the results of the OATS and the EMGT to our population? What are the pitfalls? What are the benefits? What do we take home from these RCTs? So, developing world economy, low or middle levels of GNI per capita. In 1999, it was found that it was less than 10,000, or less even for that matter. And more than 80% of the world live in our part of the world, as we call it, as emerging economies or developing countries. And glaucoma is the second leading cause of global blindness and the most common cause of irreversible blindness. And India is set to be the capital of glaucoma by 2020, according to Quigley's article about glaucoma in 2020. Existing facilities and standards of care, as we all know, have major drawbacks and are not standardized as of now. Now, do we screen glaucoma with a prevalence of 2%? We don't think so. That would be a waste of resources. Case detection. Now, that is something that is being missed even in the regular clinics in our hospitals. So, the idea would be to do what we call opportunistic screening, which means a patient comes to you for pterygium, you make sure you look at the fundus. You try and do an intraocular pressure measurement. You try and do a gonioscopy. At least look at the fundus and look at the optic nerve. By looking at the optic nerve and the posterior pole, you're definitely picking up glaucoma, you're picking up diabetic retinopathy, or you're picking up a neuro-ophthalmology problem. So, opportunity screening for the disease would be a much better approach than looking for glaucoma per se, because you're not going to find it that easily. And of course, there are competing costs. Would anybody or the government or any funding body fund that, or fund how to do sanitation and healthcare, and fund cancer research, or fund cheaper cardiology surgeries, cardiac surgeries? So that's a question. So, like I mentioned earlier, what's a good number needed to treat? That depends. If you're going to prevent one death from rabies, then you give rabipur vaccines to 200, and 1 in 200 is a great number. But if you're going to prevent, like I mentioned earlier, one structural defect from developing, then 1 in 20 may not be a great number for a developing country or from a developing perspective. So there's something also known as population attributable risk. It is the percentage of risk in a population associated with the risk factor that may potentially be eliminated if the intervention is done. And that will then help us decide whether there is a public health issue or not. So a population attributable risk of 20% can be reasonably significant. 40% is great, and that's what the government agencies look at to, say, for example, interventions like provision of clear drinking water, sanitation, and immunization. The number needed to treat, or the par, from attributable risk from the old study extrapolated was about 8.5%. That's way too low for anyone to even look and notice, at least from an epidemiologist's perspective. The EMGT gives a much better result. It looks at about 20%, and that would then maybe be qualified as a health issue. I'm not going into the digits. I think Dr. Ratra is going to sort of talk about this later. So, in conclusion, treatment of ocular hypertension has an NNT of 20 over 5 years. Targeting high-risk cases can reduce this to a justifiable 6 or even less, which is great. Now, the NNT for the EM early manifest glaucoma trial was 5 to 6, and targeting again high-risk patients can further reduce that number to 3. The effective population attributable risk for ocular hypertension is about 8.5, suggesting that it's definitely not a health issue. And an effective power of 20% for early glaucoma is high enough for it to be considered a public health problem. And with that, it might just be enough to include POAG as a priority area for Vision 2020, which it is right now. Now, there are issues with opportunity costs, logistics and resources, and probably remain outside the realm of most public health budgets in emerging economies. And primary surgery may be a treatment of choice in confirmed cases, given the added health costs and the long-term problems with long-term treatment. And use of primary mitomycin may need further study with regard to, say, potential side effects, if you look at the CIGIT study from a developing world perspective. Thank you.
Thank you, Vinny. I'd like to first. I would like to cover some of the aspects of normal tension glaucoma and what is the role of the randomized studies which you have and how we apply in clinical practice. First, normal tension glaucoma is a subset of primary open-angle glaucoma. In the clinical presentation itself, studies have shown that when you look at the normal pressures versus high pressure glaucoma, the defects are slightly, probably, the demographic data is probably slightly different. When you look at this, while everything looks normal, the only thing is they seem to have slightly thinner cornea and it's probably more female predominance. So demographically, it's probably slightly different. And the visual field data on the demographic shows that there is probably more localized field effect than diffuse field effect. And as shown here, they can get more localized visual field effect here. And disc hemorrhage, localized non-fiber light effect as shown, and localized field effect as shown are typical of normal tension glaucoma. One of the studies which is probably we all have to know is the collaborative normal treatment glaucoma study, where the purpose of the study was way back in 1980s when this study was conceptualized. There was clinical intuition was mixed. Some thought it was a condition was probably optic neuropathy and not a glaucoma, and probably IOP has nothing to do with this condition. So Stephen Drance and Dr. Anderson were the two lead researchers on the study, and what the study found was when the patients were randomized to treatment versus no treatment in normal tension glaucoma, while 28 died, that is 35% of the control progressed, only 12% of the patients treated progressed. So meaning thereby that treatment probably had a potential beneficial effect in patients with normal tension glaucoma. So when you look at the overall analysis, you can make out that probably even in patients untreated where would need progress, probably the intraocular pressure had no role. So maybe it's unrelated to IOP in certain subset of patients. While 28% of the 28 and 35% of the untreated eyes worsened within 3 years based on the study criteria, 61 showed similar deterioration in the treated eyes. So 65% of the untreated eyes did not worsen. So within the first 3 years, however, most eventually showed a slow progression. But what is important is 12% of the patients who were treated progressed despite treatment. That is 30% reduction in intraocular pressure. Probably they slowed the progress, but still there was a progression. The 30% lowering in the study was probably arbitrary, and filtration surgery achieved much higher reduction in intraocular pressure, but with the potential risk of cataract in those patients. So based on this study, they concluded that IOP was probably part of pathogenic process, and IOP reduction is probably beneficial. But the potential IOP benefiting effect was probably masked by cataract in the treated group. So probably if you get a procedure where you get IOP reduction without getting cataract, probably it would be beneficial. Then some analysis was done on looking at the natural course of normal tension glaucoma on patients who are untreated. And what they found was while 1/3 of the patients showed a localized progress in the 3 years, and half within 5 to 7 years. So what you have to do is, of the subjects followed for 3 years or more, 62 of the 92 did not show statistically change in the mean deviation. So meaning thereby that probably normal tension glaucoma is probably such a slow progressive disease. Maybe you can observe the patient for a few years before you jump into treatment for the patients. What they found was the risk factors were the patients were women and people who had a history of migraine. Patients with disc hemorrhage probably had a higher risk of progression. Probably race and family history is important because probably it's more common in the Japanese and Korean race. It's important to remember that this study, which was funded out of the NII, was founded by the Glaucoma Research Foundation. It cost 1.1 million, and it took 14 years to complete the study because NTG is such a slow progressive disease. In a slow progressive disease, it's difficult to see the progression unless you see the patient for a long time. So based on this, what are the implications of the normal tension glaucoma study? Probably the natural course is probably variable. The prediction of untreated course is probably not impossible, but we need to follow the patients. But we know there are some risk factors. The reason why this progression is important because based on the old study, the EMGT, the collaborative normal, the CGX study, what they found was even in the CG study, you can see that progression, while mean reduction was good with the both surgery and medicine, both controlled the progression to such an extent that the progression was arrested. Supposing you can get targeted pressures, whether medicine or surgery, the late progression can be minimized. So if you look at this overall data of all the studies, the EMGT study and this thing, what you can see is that the amount of pressure reduction was variable with the OAT study, EMGT study, and collaborative normal tension treatment. Whereas with the CG study, the individualized target pressure is achieved, and probably that's the reason why the lower target pressure, the progression rate for probably less. So look at this risk factors of progression from last studies. You can make out that probably in the collaborative normal tension glaucoma status, the disc hemorrhage and probably gender probably risk factors. Of course, IOP probably is a risk factor here. So based on this, so what you can do is the EMGT study is one study which looked at all the subset of patients with glaucoma, be it high tension glaucoma, normal tension glaucoma or pseudoexposition glaucoma. What they found was the patients with pseudoexposition glaucoma probably progress faster, whereas ocular patients with high tension glaucoma are somewhere in between, whereas normal tension glaucoma patients progress very slowly. Probably this study gives an idea how to look at patients who present to you and treat probably normal tension glaucoma probably less aggressively, follow the patient for a few years before you decide to treat them more aggressively. So rate of progression, as I mentioned in this, is probably very slow with NTG compared to patients with high tension glaucoma or pseudoexposition glaucoma. And the median time to progression is probably also different, whereas the median time to progression is much faster with pseudoexposition glaucoma compared to somewhere in between high tension glaucoma, with the longest with normal tension glaucoma. So in normal tension glaucoma probably you need to have the patients for longer follow-up before you say that there is progression. What does progression mean for individual patient in looking at clinical practice? Suppose you have a patient who starts with 0 decibels and if he becomes minus 25 decibels, he's become legally blind. Suppose the rate of progression is like 1 decibel, it means that it will require 25 years for him to become blind. A rapid progression of 2.5 decibel would mean the person will become legally blind in 10 to 12 years. So rate of progression is something which you need to assess before you really go in and jump and treat more aggressively. So this is how you need to know that we all start with 1.2 billion nerve fibers, and if the glaucoma normal people lose about 0.4% per year, whereas if the person the field detection occurs only after about 30% loss is there. So what you need to do is that the amount of the progression to visually debilitating visual defect as shown here depends on the rate of progression. What we know is that IOP lowering probably prevents progression. However, in many patients, progression can occur despite treatment. And even with low IOP, in normal tension glaucoma, patients can progress. So can we treat all patients with glaucoma by simply lowering intraocular pressure? These are two patients who progress so rapidly, and within short time they started to become visually handicapped as shown here. So there may be probably IOP independent risk factors. Maybe we'll look at neuroprotection as a therapeutic paradigm, which is to prevent the death of neurons and probably prevent RGC death independent of intraocular pressure by looking at neuroprotection by various target mechanisms as shown here. One of the things which has been, studies have shown that one of the neuroprotectors which is mentioned here is NMDA antagonist, that is memantine. Memantine is one drug which is already used in neurology in Alzheimer's disease, but unfortunately memantine in 2 randomized studies has been shown to be ineffective. Other neuroprotection is alpha-2 agonist, has been shown to have receptors, retina, and it has been shown clinically to be probably neuroprotective in animal eyes. While these memantine is ineffective in human beings, I would like to share something about the use of alpha-2 agonists subsequently. But other aspect also you should consider is that use of polyphenol antioxidants like ginkgo biloba has been touted as neuroprotective agents. And effect of ginkgo biloba extract in patients with pre-existing visual field defect in normal tension glaucoma are been shown to be beneficial, but this is needs to be confirmed in further studies. There are some more studies which have been published which show that ginkgo biloba is probably an adjuvant in the therapy of normal patients with normal and high tension glaucoma. So it's important to remember the other risk factors in patients with normal tension glaucoma is a condition called obstructive sleep apnea, which is a condition which is associated with obesity with airway abnormalities, and these patients also tend to have carotid plaques and coagulation abnormalities. Anecdotal reports have shown that treatment of obstructive sleep apnea slows down the progression of glaucoma. So maybe you may have patients who are present with rapid progression. If you put them into sleep lab and they may have obstructive sleep apnea, treatment of obstructive sleep apnea may be one of the therapeutic methods in patients with normal tension glaucoma. So when you look at the protection and the weight of evidence, various studies have shown calcium channel blockers, alpha agonists and carbonic inhibitors. Very few studies have reached the stage of clinical evaluation. One study is the low pressure glaucoma treatment study, which is a randomized double-blind study looking at timolol versus alpha-2 agonist, brimonidine, to protect the visual field. The primary endpoint was to look at the visual fields in patients in the both groups. What they found was the patients who had brimonidine as a therapeutic method in normal tension glaucoma had a slower progression of visual field compared to timolol. So it's important to remember the 4-year visual field progression of timolol was higher compared to brimonidine. So this is something which may be kept in mind, because the low pressure glaucoma patients treated with brimonidine who did not develop are less likely to have progression of visual field effect compared to timolol. The conclusion is probably, given the similar IOP loading effect, there is probably IOP, non-IOP related mechanism favoring brimonidine in patients. They looked at the risk factors for progression in the low pressure glaucoma treatment study, and what they found was while systolic and diastolic blood pressure and baseline follow-up a risk factor, they also found a diagonal curve as a risk factor. And looking at the multivariate analysis, you can see that patients who are antihypertensives were also at a risk factor. Patients who had brimonidine had a lower risk compared to timolol. So probably based on this, the patients using systemic antihypertensives, older age, low mean ocular perfusion pressure probably are a higher risk of progression. So it's important to remember that Logis study demonstrate that there is probably significant reduction in the visual progression with brimonidine compared to timolol. So based on this, based on the proof of concept, based on the experimental edition, initial studies in non-arthritic ischemic optic neuropathy, Leber's hereditary optic neuropathy, and as well as the Logis study, we know that probably there is some role for brimonidine as a neuroprotector. So when you look at treatment options based on what we have learned from the studies, probably one is you lower the intraocular pressure depending on the patient's state of damage, keeping whether it's mild, moderate or advanced, and make sure that you have good control of intraocular pressure in advanced patients with pressures are lower than 16 minutes of mercury. And treatment should be individualized for each patient with normal tension glaucoma, and also to consider patients with risk factors as treat them more aggressively. And one thing is the use of calcium channel blockers, which is being touted as a treatment for epilepsy, it should be taken with a pinch of salt, because epidemiologic studies have shown that while the patients who are treated with calcium channel blockers had an increased risk of open angle glaucoma compared to patients who are on systemic beta blockers. So oral calcium channel blockers to treat normal tension glaucoma is still a question mark, because epidemiologic studies have shown probably that increase the risk, because increased risk of because reduction of the blood pressure without reducing the intraocular pressure probably risk the glaucoma more. Whereas with beta blockers, both the intraocular pressure and the blood pressure are reduced, probably epidemiologically, probably the risk of progression to glaucoma is less. Is there more to glaucoma treatment than lowering the intraocular pressure? We have to consider the patient as a whole, consider the patient's systemic condition, consider the blood pressure, consider the other factors, and also consider the patient's systemic condition, including obstructive sleep apnea. Consider neuroprotection as probably as one of the adjuncts, but still we need further basic and clinical surgeons to suggest whether we need to change the clinical paradigm. but probably we are waiting for some exciting times ahead because we get some neuroprotector, we can treat the patient independently of blood pressure, and probably treatment of normal tension glaucoma would be more rational. Thank you for your attention.
To talk to us about the epidemiological studies in glaucoma.